Hello, I'm Dr. Jacqueline Small, President of the Royal Australasian College of Physicians. I would like to acknowledge the Gadigal people of the Eora Nation as the traditional owners and custodians of the lands I'm speaking on today. I extend my respect to all Aboriginal, Torres Strait Islander and Maori people. Together, we restate our shared commitment to advancing Aboriginal, Torres Strait Islander and Maori health and education as core business of the RACP. People living outside metropolitan areas have poorer health outcomes. The 28% of Australian and 16.3% of Aotearoa New Zealand people who live in regional, rural and remote areas have higher rates of hospitalisations, deaths and injury. They also have poorer access to and use of primary healthcare services. Yet we have disproportionately fewer members in these areas than in metropolitan centres. In 2020, the RACP committed to advancing equitable health outcomes for Australians and New Zealanders living in regional and rural locations. We want to prioritise, advocate and support regional and rural workforce and training initiatives. Last month, our board approved our college's regional, rural and remote strategy. The strategy serves to enhance our responses to this unacceptable inequity. It's now available on our website and I encourage you to read it. The recommendations are grouped within the following focus areas. Prioritise regional, rural and remote healthcare at the RACP. Build capacity and capability to provide physician training in our areas. Improve the attraction and retention of regional, rural and remote physicians. Collaborate to improve regional, rural and remote healthcare provision. And 5, respect, promote and acknowledge Indigenous peoples. I've just returned from a week-long visit to the Northern Territory to meet our trainees, supervisors, fellows and healthcare decision makers, launch the strategy and talk with them about their work. I was enlightened, inspired and challenged by my trip to the Northern Territory. I met many committed members of our college. The word vast really doesn't do justice to this land. It's as big as France, Spain and Italy combined and home to 250,000 people. My first stop was Garamilla, Darwin. Then we drove to Umungalan, Katherine, and on to Mapantwi, Alice Springs by plane. I had a productive meeting with Dr. Marco Buccino, the Chief Executive Officer of Northern Territory Health, discussing healthcare delivery in the Territory. I specifically raised the importance of protecting teaching time for trainees, a vital component of their learning. I was pleased to meet Angela Brannelly, Regional Executive Director, Big Rivers Region. She spoke of the unique opportunities to work in integrated models of care with remote communities, some only able to be reached by plane. Can you tell us a little bit about what it's like for a registrar or a physician to come and work here in Katherine?
It's very exciting. They get to see a lot of very different presentations and people who need care within the Big Rivers region. One of the things that I think is really valuable is that our consultants and our registrars get to go out to remote communities to see their patients. So, instead of us bringing patients in, for example, one of my communities is about 900 kilometres away from Katherine Hospital. And so instead of putting an older person on a bus for a 9-hour bus trip with no toilet, we're able to send our consultants and our registrars out to those communities to actually see the patients.
I met with trainees, senior medical staff, DPEs, Emma Spencer and Sarjane Thomas, directors of medicine and the CEO of Alice Springs Hospital. I was deeply inspired by the trainees and consultants I met. They are committed to health equity, Indigenous health and making a difference. We have 44 basic trainees across the Territory in total.
If you're someone who has a philosophy of health that's based in, grassroots and sort of being at the coalface, from that point of view, I don't think you could be anywhere else to train.
Some of the experiences and comments that really had an impact for me include Nathaniel, a trainee in Darwin, who said that clinically it's fantastic. Where else can you go for that? It's second to none. John, another Darwin trainee, spoke of the health inequities, the inequity between First Nations and the rest of the population, such as children suffering from rheumatic heart disease needing surgery.
The inequity that we see here and the disparity in health outcomes is probably the most obvious in places such as the NT.
Recruitment and retention of staff is a key issue affecting health services, despite the many opportunities and strong communities that exist. About 70% of patients in Northern Territory are Indigenous and, at a young age, often have serious yet preventable chronic diseases such as renal failure. This is over twice the proportion of the population who are Indigenous. It's an avoidable tragedy. Anna Holwell, head of the Department of Medicine in Alice Springs, spoke of her love of working in Alice Springs Hospital. She said, "It's incredibly interesting. I'm often seeing things that I have only read in textbooks. It's a smaller, friendly hospital and collaborative." Anna also spoke to the energy and commitment of her colleagues, 4 of whom are female physicians with stay-at-home partners. She says she wants trainees and fellows to view doing a stint in a place like Alice akin to completing a PhD or an overseas fellowship. And in turn, when hospitals are recruiting, that this experience is highly regarded. John Boffa, Central Australian Aboriginal Congress, presented data to show that Indigenous-led public health initiatives aimed at alcohol control can have a dramatic impact on admission rates. John also told something of his story and the decades-long advocacy to ensure Aboriginal people experience the same quality of healthcare as others do. Many of the services are specifically involving Indigenous professionals to provide more accessible healthcare. The Alice Springs DPE was proud to be able to meet a greater proportion of training, with exams being delivered on-site for the second year. Purple House demonstrated that innovative models of delivering renal dialysis to very remote communities can be highly successful. And it's as easy to pick the paediatric department in Alice as in Sydney, with colourful spaces, motivated staff, and the head of the department wearing a dinosaur t-shirt. The medicine practiced in the Territory is like nothing else most doctors will see elsewhere in Australia, and I'm very grateful to have visited. I want to thank the many people who welcomed me, including Amungana Community Health Service, Nick Buckmaster, immediate past Chair of College Council, for his role in the regional, remote and rural strategy, Simon Quilty, Richard Bard and Don Campbell, physicians who practice in Northern Territory and helped plan the trip, Richard Johnson, Executive Director, Medical and Clinical Services in Alice Springs, and most importantly, Lee Bradfield, Manager of Indigenous Strategy, and Catherine Economides, SEO of Northern Territory and South Australia Regional Committees. They organised the trip and were my fabulous travel companions. Some of our most urgent and challenging healthcare issues are in regional, rural and remote Australia. And so are some of our most motivated, versatile and resourceful physicians and paediatricians. Thank you for watching.